Okay, moving on with the program, we have Dr. Xin Liu, who is a research fellow with Therapeutics Research Center and the Antimicrobial Optimization Group at UQCCR. Her research focuses on the application of advanced imaging in functional evaluation of drug transporters and mechanistic understanding of nanoparticle disposition at a single cell level in the liver and kidney. Dr. Liu is also interested in physiologically based pharmacokinetic modeling of nanoparticles and therapeutic cells, and I may say that she's a great modeler. So welcome, Xin.
Thanks, Patty, for the introduction. So today I'm going to share the general procedure I'm using to develop the population PK model while I'm using the caspofungin as an example. So as the other started, our aim is to describe this caspofungin PK in this particular population and also want to use the developed model to do the dosing recommendation. So the software I'm using called the Monolix that was developed in France initially, and it is a parametric method. So there's assumption there, all the parameters follow the log normal distribution within the population. And this diagram just shows the user-friendly interface of this software. Before I started to do the analysis, what I did is the literature review to help me understand the PK and PD of the drug. It is an antifungal that exhibits a concentration-dependent activity. Most of people use the AUC24 over the MIC as the PK/PD endpoint. And according to the guideline, the drug was given by intravenous infusion, usually over 1 hour, with the loading dose of 70 milligrams, but the maintenance dose will based on the body weight. That gives me the hint the body weight might be the key covariates we need to look at during your analysis. And more important, the drug is mainly eliminated through the hepatic metabolism. Only less than 2% of the parent drug is excreted through the urine. So the patient's liver function might be more important than the renal function to determine the PK of the drug. Both the 1 and 2 compartment model has been used for the PK analysis, and some covariates like the body weight, the gender, and the lean body weight, and albumin has been identified. So the next step I did call the exploratory data analysis. That mainly is to summarize the patient's characteristics. This step is useful, especially you have the large data set and complicated patient's population. And for my one, it's a very it's a subgroup started from a large clinical trial. So only 8 patients included. 5 of them were male, and I noticed the body weight of these patients ranged from 55 to 133, quite large range. And then I look at the data I'm going to model is only the plasma concentration. And they were all sampled within the second dose interval. And the last sampling time is 24 hours after the dosing. Then I move on to the real analysis. So the first step is to select the base structure model. And I test a 1 compartment model, 2 compartment model with the BSV between subject variability on all the parameters. And then the between subject variability only on clearance and the volume of distribution of central compartment. There are some values from the output you can use to help you select the model. Monolix recommended to use the BIC, Bayesian information criteria, to help you to select the base model. According to this criteria, the lower the better of the model. Probably I need to choose 2 compartment model and consider the BSV on all parameters. But then when I look at the parameter estimates, I noticed the parameter estimate from the two compartment model was actually not quite reliable. This was reflected by this higher ISE value, this relative standard error of your parameter estimate. And that make me be very cautious to use this model. Then I look at the goodness of fit plots. I found actually for one compartment model, there's no obvious bias there. It looks like the quite good fitting from here. So this was also supported by this VPC, Vero Predictive Check plots. You see there's no outlier here. Then I made my decision to use the one compartment model as my base model, then moved on to the next step is the covariance evaluation. Because my data got quite a few different covariance, if I test one by one, that's time consuming. So we screen the relationship between the individual predicted PK parameter from the base model and the covariance. Then I selected only those covariates that show the strong correlation with this R value over than 0.5 and also give the significance with P values less than 0.05. So that's reduced the number of the covariates I need to test. So I only need to test the albumin on the clearance and the lean body weight on the volume of distribution and the gender effects. So for covariance evaluation, I follow the forward inclusion and backward elimination method. We add each covariate to the base model and then rank them based on the decrease of this OFV. Usually we think over 3.84 is the significant decrease, and then add this covariate sequentially to find the full model. In my case, model 7 is my full model. After that, you do the backward elimination to remove each covariate individually. If the removal of this covariate causes the increase of OFV over than 6.63, that's corresponding to the p-value less than 0.01. We return this covariate, otherwise that will be removed. So my final model is my model 4 that only have the lean body weight effect on the volume of distribution. So this table just summarizes the final parameter estimates from the final model. It's a one compartment model with the first order elimination and the residual variability described by the additive error model, and only have the lean body weight as the covariance for the volume distribution. And we also perform the bootstrap as the internal validation. The median value from the bootstrap was close to the model estimate. And then we further do the model evaluation based on the goodness of the fit plots, and also using the VPC as the evidence of the model validation. So in summary, the procedure I followed was the first to do the literature review, get the general idea of the PK/PD of the drug, and then to understand your population, your data. Then next step is to select the correct base model. Based on that, to do the covariance analysis and then do the model validation. Eventually, we can use the validated model to do some application. This was not shown in this presentation. So I think that's all my talk. Thank you for your attention.
So we'll just take some questions. Does anyone have any questions? Oh, hang on, oh yeah, anyone got any questions for Xin? I don't think I've got any online. Hey. Okay, that's all right.
So does ECMO have any effect?
Yeah.
Cool.
You want to describe the effect?
What? I didn't.
That's all right. Steve was asking, does ECMO have any effect?
No, because all the patients receiving the ECMO, we can't test the ECMO effect. That's the problem of the study. Yeah.
Thank you. I'll just ask Patty.
Thank you, Jin. That's a very nice workflow for the modeling process. So I think you made a very interesting comment that when you, in terms of selecting a structural based model,
Yeah.
so you had the two compartment model with lower objective function value,
Yeah.
but you preferred the one compartment model based on the relative error for the parameter estimates. I was wondering if you go further with this two compartment model, would the covariates minimize the error, standard error for the parameter estimates? And the overall objective function for the final covariate model would be lower for the two compartment with the covariates versus the one compartment with the covariates. Is this a possibility?
I think that could be some possibilities there. So I actually did a little bit explore, but the danger of this one is when you do that way, sometimes it's hiding some real covariate effects. That's what I found here. When I use this two compartmental model, while while not considering the twin subject variability for the Q and the V2, I choose this two compartment model to do further the covariate analysis. That's gave me some, I couldn't identify this lean body weight as the covariate. But when I go back with one compartment model, I found the strong correlation. So I just think you can do both ways, but eventually you need to use extra things like those goodness of phase plots and the VPC plots, not just rely on the one value to make your decision. Explanation, have you tried to incorporate allometrically into the re-examining what was the condition number of the so for the first question, I didn't do that allometrically for the two compartmental model. The reason for that is because this two compartment model, if I consider the between subject variability for all of them, this gives extremely strange value for this Q. That make me think my data probably not supporting this kind of estimation. That's why I didn't go further with this model. Instead, I do a little bit extra things for the two compartment model without the BSV on Q and V2. But when I adding this body weight effect, there's actually not an improvement of the modeling. So I didn't go further. So for the what was the condition number of the two compartments, I not quite understand the point. So I'm not familiar with this terminology. What's the conditional? Yeah.